and we are going to talk about how to do the laser ablation of varicose veins. It's a very, very vast topic, and it's just impossible to cover in one talk, but we'll try to cover as much as possible. And I put in 6-7 slides about other methods also, but mainly we are going to concentrate on laser ablation. There are a lot of videos I can show, but just showing the procedure, because the total procedure time is 10 minutes. So, just showing the video may not be, because in laser ablation, the most important thing is what to do, what all things to decide, and basics of laser is very important, I feel. Doing the procedure itself is not very difficult, and so you can train people to do it very easily. And but the understanding the physics and the lasers and what not and what is there in the literature is very difficult. So it's not, I have not put in very academic, boring slides from the literature, but tried to be very practical, what we think in a day-to-day practice. I don't have any conflicts of interest with any company. We all know C classification, okay? So there are basically, we classify them into C1, cosmetic varicose veins, C2 into with basic hair, C3 edema and the varicose veins, C4 pigmentation, lipodermatosclerosis, C5 is healed ulcer, and C6 is venous ulcer. Now the important thing is you must know that there is a modified C classification published in 2020, very recently. So there are three important things which has changed in this. One is we have also included the recurrent varicose veins, C2R. Then the C4 stage has been divided into three. One is the pigmentation eczema, lipodermatosclerosis atrophy, corona phlebitis, and 6CR includes a recurrent active venous ulcer, because so these things were not there in the earlier SEEP, so they are now included into this SEEP classification. So I think it's very important for everybody to understand this and learn this, and maybe take a photograph, because if a patient comes with a recurrent active venous ulcer, it goes into a very advanced C6R stage. In terms of investigation, Duplex scan is one of the best investigations, as you know. And if you have to get more investigations to evaluate the deep systems, you can go for MR venograms or CT venograms. Conventional venograms we normally don't do, just for diagnosis. Why do we need to operate varicose veins? Because it's associated with various complications, as you know. And one of the most important complications which we see in our clinical practice is rupture, varicose veins, with bleeding, around 2 to 3 cases a month. Lipodermatosclerosis, one of the very common presentations. And a thrombophlebitis is another very common presentation, what we see in our clinical practice, maybe 6 to 8 patients a month with superficial venous thrombus, and which we treated with the anticoagulation, and 6 weeks later we do investigate, and if required, then we do the laser ablation. Now there are various treatment options which are available in the market. Besides stockings and drugs, there are sclero, radio, surgery, lasers, RF, steam, microwave, glue, high force. You can see variety of options which are available. So my personal favorite, of course, is always laser, and there are various reasons for that. But we are just going to touch base one slide of each other procedure also, so that anybody who is not aware of the other procedures, so they get at least basic knowledge about all the other procedures. The reason for that is also very important, because a lot of patients, because they go on the Google and search for it, so they come to you that I want a glue. So, if you try to convince that patient to get a laser or radio frequency or something like that, so, normally the patient does not come back. So that's why in our center, we do all these procedures very routinely, except in HIFU. So high intensity focused ultrasound, which is not available in the world, is available only in one center at present. Second important slide is medical point. Chronic inflammation, we all know that may be the cause, that the valves are destroyed. And there are various ways to look into this, but the only drug which there are some studies which shows are important to control this inflammation is a venoactive drug, micronized purified flavonoid fraction, or the commercial name is Taflon. So it's given 1 gram a day. So you can use this. It has been shown that It decreases inflammation in the walls and may prevent the progression. Now, surgery. So this is one of the earliest patients, around 10 years back when I think this is one of the last patients. We have stripped the long saphenous vein, and this is also under local anesthesia with Tumescent. So this is also not under spinal or GA, and you can puncture and take the long saphenous vein at the knee level, then pass a stripper, then under ultrasound, see the stripper on the down there, make a small cut, and take the vein out, ligate the long saphenous, strip the whole long saphenous vein after Tumescent. So open surgery is a good method wherever the laser is not available. So I'll say that surgery is not out, especially in our country where laser cannot be afforded by everybody. So especially in the government hospital, and I feel surgery will still have a place in our armamentarium. Coming to minimal invasive interventions, so we got laser. This is one of the very earliest slides. As you can see, this is one of the first biologic machine. I think this picture is of 2006, and we were doing a laser ablation here. This is a bare fiber of the laser which is used, and within portable ultrasound. So this is a procedural video. So just to show you how it works and how do we do it. We do it under local anesthesia. We don't keep our patients fasting. Patient can eat and drink. They can have breakfast half an hour earlier or 1 hour earlier. We, as a practice, don't do any routine blood investigations except if the patient has some medical disease and we investigate it. Otherwise, we just get an RBS done pre-operatively. Patient is, we don't do any shaving. Patient walks into our OPD. We take the patient into pre-operative, change the clothes, take a consent, and patient, we put in a cannula definitely, and the patient is on the table. Once the patient is on table, so we drape the patient, clean the patient. You need to keep on talking to the patient so the patient is comfortable because it's under local anesthesia. So we give 1% lignocaine, around 2 ml, wherever we want to do the puncture. Under ultrasound, you select a place. So once you have selected a place where you want to puncture, we take an 18 gauge needle and we pass a 0.35 guide wire into it and put in a 6 French sheath inside it. So once you have a 6 French sheath inside it, then you take the laser fiber inside through the long saphenous or short saphenous vein, place it near the saphenofemoral junction. Once you have placed it, you give a Tumescent anesthesia. After Tumescent anesthesia, you burn the vein and take the sheath out. Normally, if you burn the vein properly, you just have to press the insertion site for maybe 30 seconds and there will be no bleeding. So if you look into all the other methods, there will always be a bleeding from the sheath, except the laser, where in sometimes if you do proper laser, you don't get any bleeding at all from the sheath entry point because the vein really occludes very well. So let's see this procedure video here. It's not my video, it's a company video, but it was very nicely made, so I've just taken it to demonstrate. It's nice ultrasound video. You can see a 6 French sheath is a green sheath, and you put in, this is a radial fiber. You can see very nicely and illuminated, and it's an animation along with it. Into the long saphenous vein, you gently take it. You can see the fiber, the black color is the vein. You slide the fiber along the vein as you see it on the ultrasound on the simultaneously on the side, and you place it at SFJ. Then you take an 18 gauge needle and you use the Tumescent. This is the two facial layers of the saphenous vein on the side. In the center, there is a vein along with the laser fiber. Here we have placed the laser fiber at SFJ junction, absolutely at the junction, and then you either fire the laser continuously mode or an interrupted mode. We'll discuss about that. And you take the laser fiber slowly and slowly down and burn the whole vein. You have to be very careful that you don't burn the sheath. So wherever there is a black marker which is there on the laser fiber, as soon as you reach there, you need to take the sheath out, and so that the laser fiber does not burn the sheath. So once we have done this, you need to understand various questions and answers. Now, which laser is the best? So we have 810 available, 980, 1470, and 1940. So you have to understand this graph. Look into this. If you look into 810 and 980, the maximum absorption is by the laser energy is by the hemoglobin. But as you keep on going down, let's say after 1000, the maximum absorption of the laser energy is by the water. So we feel that if you have a 1470 laser energy, that gives you the best absorption into the water, into the vein wall, and into the water of the blood, and that produces a very good closure. Now coming to 1940. So 1940 is another step forward after 1470. We have done around 50 cases, and we have been doing it from 6 months with 1940 laser. And the only difference we found was that there is less bruising than 1470 even, and the less heat. 1940 is more absorbed by the water than the hemoglobin, and it is. We are going to see this next slide. If you look into this, so that is 400 times higher absorption in water than 810 nanometer. So that's a very important aspect of the 1940 laser, and it is 40 times higher absorption with water than 980 nanometer. So we are going to discuss this heat absorption and all, why that is important. So is 1470 and 1940, is there any difference in terms of clinical results? We still don't know. If you look into the closure rates with 1470, so they have actually reached nearly 99%. There are some studies which have published 2 years closure rate to 100% with 1470. And there are some studies which have shown 2 years closure rate with 1940 nanometer also as 100%. So you cannot go more higher than 99%, 99.5% closure rate. So I think we have already reached the highest level of the laser. So I personally feel they may not be any much difference in 1940 and 1470 laser, but we don't know. There may be a long-term effects which we don't know. Definitely lesser energy is used in 1940 than 1470, so that may be gentle on the patient. 1940, you may be able to treat the epiphyseal veins. There are long saphenous vein which comes out of the fascia, and it's a very big long saphenous vein just near the skin, where we either have to do phlebectomies or foam, because if you do the laser near that, it forms a very big cord. So we have done 3 cases in 1940, and it does not form that cord. So maybe that there is a role for 1940 laser, and which we are trying to find, and in the next 6 months will be much better to know. Now you need to understand different fibers. The Bayet fiber was one of the earliest. It has a core of 600 micrometer, and then on the top of that it also has a fibrous cap which is around 200 micrometer. So it's a thick fiber which is there. Then where a fiber had a problem because it used to release a lot of energy, and it used to perforate the veins. People used to have more pain and more bruising. So then there was newer fiber developed, like a tulip fiber, never touch fiber. But both of these fibers, I don't want to go into too much detail, but both these fibers could never pick up into the literature. So I will not talk much more about that. Then a radial fiber came in a few years back. It was developed by 2 companies. Biolitech was one of them. And the tip diameter of the radial fiber is 1850 micrometer. It passes easily through the 6-inch sheet, and it basically radiates all around. So if you look into this, this is a very close-up of the radial fiber. So there are 2 prisms in the radial fiber, which are 6 millimeter apart, and the laser energy. So let's say if you want to deliver 8 watts, so it will be delivered half. If there are 2 rings, it will deliver half in the front and half at the back. So it divides the energy into 2 points, and it radiates the energy all around the fiber. So look into this. This is a very important slide. If you look into the Bayet fiber, look into the dash slide, how the laser energy will be delivered. So if you look the way it's delivered, So the whole energy, the higher energy was delivered here. It used to perforate the veins. As compared to the radial fiber, it radiates all 360 degrees, the laser energy, and also because if you use a double ring radial fiber, it reduces the energy at a particular point much lesser. And at the same time, if you use 1470 or 1940, as the absorption in the water is much more, so there is a direct heat absorption into the vein wall also, along with the heat absorption into the water of the blood. So this is the radial fiber. Now radial fiber has got multiple types. One of the most common types is a single ring or a double ring. So as you can see very clearly from the diagram. Now, what is the advantage of single ring and double ring? There are not much studies published which has shown any difference in the single ring and double ring, except double ring is much more expensive. It will be 7,000 to 8,000 rupees more expensive. Why was the double ring developed? People thought if the proximal ring which is there, if we fire it, it will cause the vein into spasm, and when the next ring will come over there, it will be much more closer to the vein wall and the radial fiber, and it will burn the vein much better. There was also another theory that if you burn the radial fiber with a single ring not in a continuous mode but in an interrupted mode, because in that, if let's see, the ring is, can you see, it's only at one point, but we withdraw the fiber every 1 centimeter. So maybe that we are able to leave some space in between with the vein which is not burned. So let's place 2 rings there so that we can burn the vein totally in the whole 1 centimeter area which is there. So but if you look into the publications, the closure rates with single ring and the double rings, they are nearly similar. So really I don't have an answer to this. Then you also need to know more development in radial fiber which are there. One is a slim fiber. Slim fiber is also very slim, and of course you can see the diameter difference. From the 2 ring is 1.9 millimeter. 3 millimeter. That's the slimmest fiber. So you can actually pass it through a 16 gauge cannula. So you don't have to put in a sheath at all. There are various uses for that. Then there is radial swift fiber. That's a single ring fiber, and it's around 1.6 millimeters, slightly more. So you can pass it through a 14 gauge cannula directly. You don't have to put in the sheath. Then you need to understand the heat transfer mechanisms in a vein. So once you fire a laser into the vein, into the blood, there are various things which happen. So how does the vein wall get closed? So there are various theories. So you will be very surprised. 20 years down the line, we still don't know exactly how the laser closes the vein. We have got some theories, and there are various theories, but exactly how it closes, we don't know. So the theories are that the heat gets absorbed by the water in the blood, and that heat gets radiated to the vein wall. Second is there are bubbles which are produced here, especially by 1470, because 1470 gets absorbed in the water and water of the blood. So that's why if you look into the 1810 nanometer laser, you will not see bubbles in the vein on an ultrasound. But when you use 1470 or 1940, you will see a lot of bubbles in the vein wall. So that's why people feel that these bubbles, they carry the heat into the vein wall, and that's why you get a better closure. There is not direct laser energy which is damaging the vein and causing the perforation. So another thing is the heat energy, the laser fiber energy gets absorbed into the water of the vein wall. So once it gets absorbed there, then these water molecules in the vein wall will heat the collagen and damage the collagen, causing the fibrosis. So there are various theories which are there. Exactly we don't know. Then another very good concept is about carbonization. You see, when you heat the vein and when the fiber gets heated at the tip, all the protein and the collagen is coagulated at around 60 to 80 degrees. And the temperature at the tip of the fiber is around 100 to 110 degrees centigrade. But if there is a blood which gets heated too much, and if there is a lot of blood into the vein, then you will get a carbonization. And if there is a carbonization at the tip of the laser fiber, then the temperature at the tip of the fiber can go up to 700 to 800 degrees centigrade, and can and the heat which is there in the fiber will not be transmitted outside, and you will get a poor result. So that's why carbonization on a laser fiber is not a good thing. Then there is some concept of calculation of treatment energy. It's based on that if you look into the diameter of the vein in the lying down position before Tumescent anesthesia, and you take the diameter of the vein and multiply it by 10 watt or 8 watt depending on the fiber. But there are other studies which shows that the diameter of the vein does not matter, how much energy you're going to give. So they have seen in different studies, and they have shown that different diameter veins with the same energy can be closed very nicely. So you can imagine this also, still we don't know, but laser is one of the only technology which gives you a freedom that if there is a venous aneurysm on the way while you are treating the vein, you can increase the energy and damage that vein much better. Coming to Tumescent anesthesia is given to control the pain, to separate the perivenous tissues, to protect the perivenous tissues, to empty the vein of blood, and it also improves the contact between the fiber tip and the vein wall. And when you give the Tumescent anesthesia, it should be all around the vein. So on the center, you can see the white color thing. So that's a vein with a little fiber, and it should form this black color hollow around the vein. So that is considered to be a good anesthesia. If you give a good anesthesia, it should be like this. And if you get like this, you will see that the patient does not feel much pain, and also you will not use huge amount of anesthesia to close and get all these benefits. And you can actually deliver the tumescence much faster. You can actually deliver whole leg tumescence only in 2 pricks. Then there are various parameters to look into the tumescence. I will not go into detail, but these are the parameters to think about, and it's a different talk. Then you need to look into the lignocaine safe doses. I will move on this. Now this is the tumescence constitutions, and so this is a standard constitution which needs to be used. We have actually stopped using soda bicarb like 4 years back. Because we have stopped using normal saline. So we prepare all our solutions in ringer lactate. So if you use ringer lactate, then you don't need to use soda bicarb at all. This is, look into the size of the veins here. Another example. People say that you cannot treat this with laser. We treat it all the time, maybe much more bigger veins than this with laser and foam, totally minimal invasive, and pre and post operative. So this is on table. Patient is on the lying position, and you see I have punctured in mid thigh, not down. The reason is because the saphenous reflux, which is there from the saphenofemoral junction, the vein was around 22 millimeters in the proximal thigh, and in the mid thigh it has come out of the fascia, and given that, so the reflux has passed from the long saphenous vein into the superficial varicosities. So below this, the long saphenous vein is only maybe 1 to 2 millimeters. So I don't need to puncture that vein, and I can puncture the vein here in the mid thigh because I'm treating the refluxing long saphenous vein, and then I'm going to treat the varicosities. So here we have put in the 6 French sheet. We are using a double ring laser radial fiber. It's a 1940 laser fiber. So once we have treated that, then you got a lot of varicosities down there. Now there are various ways you can treat the varicosities here. You can leave them alone and come it another day. So this is another protocol which is coming up these days, that you treat the main vein, leave the varicosities, and come after 6 weeks to 3 months, because the reflux will go on, these veins will become smaller, and you have to use less foam or less phlebectomies. Another is you do the phlebectomies of all these varicosities. The third is you put in a foam. Now there are various ways of putting the foam if you want to be totally non-invasive. One is you put in a 3% STD or polydocanol directly into it, but if there is a blood in such big varicosities, you will get a lot of coagulant. If you do that, call the patient after 3 days and remove the coagulant with a needle or a 11-number blade. Other way is you put in the scalp vein, and then you can see the green needle. I'm giving the tumescence anesthesia all around these veins and making these veins compressed of the blood, and the blood will start coming out of the scalp veins. And then I'm going to flush these scalp veins and make sure that when I flush any scalp vein, the saline comes out of the other scalp vein. So means I have actually washed out the blood from these varicosities. Now it takes time. It takes around 10-15 minutes to do all the setup procedures, put in like 4-5 scalp veins, give tumescent anesthesia, wash out the blood out of them, and then give the 3% foam. What happens with that is the requirements of foam becomes very low. So if you can imagine such big varicosities, you will use around 12 to 15 ml foam. That's all, and you can get such a good results on table. So this the patient is still lying down, and you can see we have done the foam and the laser, and there are no cuts of course the stitches, and you can see the size of the varicosities which is there. And when these patients come, and then we give the compression bandage, of course. There's another case, where we have done the laser and the foam, and you can get microfoam was also done in this, and you can see around 3 months follow-up, you can get fantastic results. Similarly, venous ulcer, you can keep on putting these pictures, but that's not important. Now, important over here is give an antibiotics, take a culture, put in a 4-layer compression bandage, and once the ulcer will start looking good, and then you can do under local anesthesia, a laser, and you can take a skin island, from the top. And these days you can also use an artificial skin on such a small wound and get these ulcers healed. Then there is small words about laser crossectomy. So this is a new concept. We have been doing laser crossectomy for more than 2 years now, and done more than 100 patients. And what that concept is, you see the safe distance from saphenofemoral junction is around 2 centimeters, which is there in the literature and in the guidelines. Then there are some guidelines which shows that you can go up to the 1 centimeter in some patients. Now, from last 2 years, what we people saw that when you follow up this patient, there is a reflux in the interior accessory saphenous vein. So patient comes back to us with a recurrence. So in these patients, to avoid this recurrence in 14 to 18% of these patients, what we can do is we can take the laser fiber up to the saphenofemoral junction and burn the vein from the junction. So what will happen is this laser crossectomy is just like doing a surgery. When we used to do an open surgery, we used to do an FFA ligation of the junction, ligate all the tributaries. But what was the problem was that we used to get a lot of recurrent varicose veins. So, but now we are coming back again to a surgical sort of crossectomy with a laser, but we don't know how these patients are going to behave in the future. So the follow-up of laser crossectomy is only around 2 years now in the literature, and they showed the recurrence rate is not higher, actually it's much lower than the laser, because you don't get a recurrence in the interior accessory saphenous vein. Now, what is the drawback of laser crossectomy is you need to be really perfect in ultrasound. You need to be really good in giving a tumescent anesthesia, and there will be a small risk of causing an deep vein thrombosis. So that's why you have to be very careful what you are doing. So I will not advise this in the beginning. You must do around 200-300 cases, then only go for laser crossectomy. Because if you do a laser crossectomy and you cause a DVT, so patient, you cannot be spared, because this is not a standard care or standard practice of doing a laser crossectomy. But if you keep the fiber 2 centimeters away and the patient comes back with a recurrence with an anterior accessory saphenous vein, which is going to be only 14%, it doesn't matter, because that's a standard practice, and 14% recurrence rate is a common thing in varicose veins. So you will be very safe. So, that you have to choose now what you want to do. So this is just a laser crossectomy. We are doing it, and you can see the laser fiber just at the junction, and you can see the epigastric vein on the top coming out. So I'm keeping the fiber just proximal to the epigastric vein, and then we're going to use a tumescent anesthesia and do it. And just one of the examples you can see here, total closure of the vein at the junction. So there is no reflux into the stump, into such a big vein, and so you need to give a tumescence very well in such a case. Then you got a very big perforators you could have, and in the calf or in the thigh or posterior thigh, which you can close with a laser. And this is just one of the examples. We are using an 18-gauge needle to puncture ultrasound guided this huge perforator, which is there, and you can see the reflux. Can you take the phone, please? And so there is a reflux here on an ultrasound, which you can see. So we have punctured it with a bare fiber, and this was all the varicosities were coming from this perforator. So patient did not have anything. Now you can close this perforator with a foam also, but this perforator was more than 4 millimeters or 5 millimeters, a very big perforator. So when it's a very big perforator, we try to close it with a laser. Otherwise, most of the perforators you can do it with a foam. And so this is how we place it, and then we give Tumescent anesthesia. You can see here, and then we do the laser of the perforator with the base fiber on ultrasound, and slowly burn the whole thing, and all the superficial varicosities we can give a foam. So this is a very nice way of closing the perforators. So we have closed perforators, very big perforators, around 2 centimeter perforators with this. And but I still remember very big mid-thigh perforator which we closed with a laser. It opened up at 6 weeks later, and so it's not like you will get 100% results, but yes, more than 90% of the perforators can be very easily closed with a laser and the foam. Steam ablation is another method of burning the vein. I will not go into detail. It's a B-box which is used for steam ablation and which can burn. There is another microwave technology which is there. So we have done around 25 cases with this technology, and this is a newer technology which is coming up. What's the advantage of a laser? I really don't know because the standardization with microwave is still happening around the world, and the protocols are being made. And I think we are evaluating this technology and as compared to laser and RF, and we'll come to know. So radiofrequency ablation is another very good method which can be used to close the veins. Can the improvement be made to the thermal ablation? Yes, non-thermal techniques are there. One is MOCA, mechanical occlusion with foam and glue and a foam sclerotherapy. When we look into the MOCA, there are two basic techniques, Claravin and Flabograph. Claravin is American, Flabograph is a Poland technique. Claravin is an electrical occlusion. We basically damage the vein inside with a mechanical vibrator, and then we inject a liquid foam, a liquid sclerosant. In Flabograph, you can switch off the mics here, guys. Yeah. Flabograph is a mechanical thing by which you scrap the vein and you can inject a foam sclerotherapy with Flabograph. So we have done Flabograph around more than 250 patients with 3 years follow-up now, and Claravin we have done only 4 cases, so we don't have huge experience with it. So this is just a small animation just to make you understand how it does work. We pass the guide wire, we pass the device over it, we open the blades. This is a mechanical one, it's a Flabograph. We open the blades from the top, and then we inject a 3% STD or polydocanol, and there is no Tumescent required, no local anesthesia, and patient can actually walk home. The closure rate with all these technologies are not better than laser and radiofrequency. So I feel there are some particular patients where you can use this technology, but not as a standard of care. This is just one of the examples with the foam and MOCA what we've used. Then there is a glue you can use, is a Medtronic glue which is available. Then there is Invamed glue which is available. You can use any one of them. The difference is Invamed has got a faster polymerization rate. Medtronic has got a slower polymerization rate. There is a lot of experience with both the glues, a lot of publications which are there. The only drawback I feel is there is a constituent which delays the polymerization in the Medtronic glue. We feel that may be the cause of the granulomas. So there are a lot of more than 10 studies has been published with Medtronic glue causing a granuloma in the skin, and a lot of people are afraid of putting a foreign body into the vein. We have done around more than 150 patients with Invamed glue in last 3 years, and so we haven't seen not a single patient with granuloma or complications. The only complication I feel with Invamed is a huge learning curve as compared to Medtronic. Medtronic is slightly easier than Invamed, and second is if you the cost which is there as compared to the laser fiber. Just one of the examples here. High intensity focus ultrasound is another technique which should be
positioning is controlled via the system.
Which is
be safely applied
is being evaluated now, and
so we will know eliminating the risk of stump formation after treatment. Thanks to its non-invasive character, the beam can follow virtually any path, even tortuous veins, regardless whether big or small.
So HIFU it's being evaluated now, and I think it will be another 4 to 5 years before it comes to the market because we need to look into the results. Second, it's very expensive and it does not offer a huge amount of benefit over the current techniques in terms of long-term closure rates. So at present, I think we should keep that under the wraps and we should keep on evaluating into research and see. Cosmetic varicose vein, telangiectasias and all, there are various techniques by which you can close these C1 varicose veins directly with a sclerosant, or you can use a transdermal laser along with the sclerosant, what we call a Clark's technique. So you need a very different setup because it's very expensive machines you need to use. So this is our hospital setup in our clinic here, what we are using, and you can see what we are using here is three techniques, three things. One is the NDY laser, which is there on my right hand with a red spot. Then we are using a coolant so that the damage to the skin is not there with the laser heat energy. And third is the transillumination. So we are using the vein viewer by which we can see the veins which we cannot see by naked eyes. So that's basically three things which we are doing here. And this is a small video. You can see how the veins get illuminated with an infrared. And we are using a 6 mm spot over here with a pulse velocity of 15 to 30 milliseconds. You can use depending on the size of the vein. And you can also use the heat energy, use around 40 to 80 joules. We can use the fluency in this to burn the vein. Once you have burned the vein, you can use the sclerosant. Either you can use the polydoxmal or STD or dextrose. Here we are using 75% dextrose here, and you can see very nicely the vein gets obliterated, and it gives a really nice clinical result. So you can see in the top, the patient has got foot veins, and I feel all the foot veins should be done with this because it's really amazing results you get with this. You can use the spider veins, reticular and spider veins. You can use, it's a whole topic. You can keep on going. Here we have done the SPJ laser with a 1470 along with the Clark's on the foot, and 6 months later you can get 3 to 6 months later get very good results. Last two slides is vulval varicosities. Vaginal varicosities you can do a foam in them, or you can remove them, or you can, if there is ovarian reflux, you can do the embolization at the top and go in and do the ovarian vein embolization. So in conclusion, treatment for the management of varicose veins is evolving, as becoming very patient friendly, and minimal invasive treatment is a gold standard for treatment of varicose veins. And I feel laser is one of the best techniques. Thank you.